All right. My name is Nancy Tourette, and I'm here on behalf of our team at APCO Worldwide to welcome you to a 1-hour conversation as part of our ongoing series on the COVID-19 challenge and opportunity. And today's topic is healthcare itself. We're going to continue to invite you to sessions on other topics. Today, I am delighted to have a distinguished panel with me of both colleagues and members of our expert advisory board, who I'll introduce you to in detail later. But with me are Bill Pierce, Jack Calapertinos, Peter Urbanowitz, Kavita Patel, and our lead researcher, Christine Zaccaro. Before we start, just a couple of little housekeeping matters. I know that everybody who's listening to this now has become a Zoom impresario in the past couple of weeks, as we all have had to. But nonetheless, this discussion will be joined by about 150 of our clients, colleagues, and a few members of the media. We're on the record, and recording for this will be available on our website, on the coronavirus segment of our website, very easy to find, along with a lot of other resources. We're going to divide this meeting into 3 sections. One will be 10 minutes where our senior researcher will present some findings and insights. Then we'll have 20 minutes where our panel will make some specific comments. I will ask them specific questions pertinent to this. And then the second 30 minutes of this call will be devoted fully to open discussion with anybody who wants to participate. When we get to that part, we'll give you directions on how to raise your hand and all of those kinds of things. But with no further ado, I am very happy to introduce you to where we're going here. For those of you who don't know APCO, it's an advisory communications and advocacy firm, and we support clients globally. Since the crisis first emerged in China, we've been working obviously with clients in every world to stay informed, engaged and ahead, and of course trying to gather intelligence that will help as waves of this pandemic hit different parts of the world. We also have a number of our own employees and are staying very close to them, and they're giving guidance as well in places that were hit first. We're also, we're finding that increasingly our clients are also asking us for technical information. So we're not going to go into a lot of detail on that here, but things like how to access your national stimulus plan, how to approach that, what makes sense, kind of consulting on that, and ways to engage governments in general in ways that are going to allow a stronger relationship between a company and its government, or between another player and its government. It's definitely a time where new ways of collaboration are definitely being explored. So when we held our first this is very sobering. When we held our first COVID-19 focused webinar just 4 weeks ago on March 11th, there were a total of 114,000 cases, including 4,000 deaths reported globally. And as of now, and I'm sure that's changing even since we last looked this up an hour ago, there were over 1.46 million cases of COVID-19 in the world and more than 85,000 deaths. The power of the exponential curve and this novel coronavirus has been daunting. Today, we want to talk about how to address both the challenges, but also see this moment of change as an opportunity for leaders in every sector. So without further ado, what I'd like to do now is introduce my colleague, Christine Zaccaro. She is Senior Director for APCO Insight, and she's going to share our latest research. Christine?
Thanks, Nancy. So as an agency, we've been interested in monitoring public opinion around the COVID-19 crisis, and we started polling the first week of March when 2/3 of Americans thought it was extremely or very serious. And now in our most recent polling, we find that 9 in 10 think that the coronavirus is extremely serious. In this installment of our series, we'll focus on health topics with the goal of understanding the experiences and expectations of the public as they deal with this unprecedented health crisis. We want to reflect on what they are dealing with now and how they see a road to recovery for themselves as individuals, communities, or the world. So let's have a look at our recent polling from March 26th and 27th. Our first topic explores vaccine confidence and views towards innovation. Hold on, there we go. Let's keep it steady. On the left, the pie chart depicts strong vaccine acceptance. 83 say they would get a coronavirus vaccine today if it were recommended to them. And a similar rate believes the result of this pandemic will be more people getting CDC recommended vaccines next year. What is interesting to me is that the views towards vaccine safety have not changed. And while most will get vaccines, there has still not been a strengthening of attitudes about their safety. Just over half remain unchanged since a year ago on their views towards safety, which is similar to data from 2 years ago when half said the same thing. Yet when asked directly, and this is not shown on the slide, since preventing the spread of the virus is the only thing that will end the pandemic, does it make you value vaccines more than ever? 2/3 of Americans agree. So with this in mind, there is a desire for more innovation. We see 3/4 of Americans thinking researchers today are collaborating to find a vaccine, whether spanning countries or working here in the US across the private and public sectors. And this translates into 2/3 of a majority who are hoping for more public funding and private sector action to discover vaccines. And the context for this, however, is that less than half believe that the government or the private companies have put enough funding or priority toward vaccines in the past. So moving from prevention to treatment, let's look at some more public opinion insights. 2/3 expect that within the next 3 months, there will not be enough healthcare providers in their area. And even more, 3/4 of Americans think that there will be local shortages of personal protective gear, tests, or medical equipment like respirators. Similarly, 3 in 5 think fake medical products will appear in their areas. In this environment of perceived shortage, the vast majority, 9 in 10, think the federal government should be involved in making sure private companies are meeting the demand for medical equipment to respond to this pandemic. But the table to the right shows that Americans are divided whether private companies will meet the demand on their own or if the federal government should force them. So what does this mean for how healthcare delivery will evolve? I'm not sure why they decide to keep skipping over to the next one, but I think it'll stay. Looking ahead to next year, 87% of Americans expect more remote or virtual healthcare services will be available, and there is an appeal for it. 3/4 say that they are interested today in using telehealth for any of their medical needs, including treating coronavirus or others. The table in the middle shows that most, 62%, say nothing is preventing them from using telehealth services. But there are barriers that need to be addressed, with doubts about quality of care, practical skills on how to use these services, availability, and equipment, which are the most frequently mentioned barriers. Also, half of Americans say that telehealth makes them even more concerned about the privacy of their health data. These are important considerations as we think about what our healthcare systems will look like in the very near future. Thinking about today and actors in our healthcare system, we also wonder how they're faring in the minds of Americans. The valiant efforts of those on the front lines, healthcare providers, hospitals, public health departments, and state governments are being recognized across the country. Half or more have improved images of each of these because of what they've done to respond to the pandemic. And in turn, many of these same actors are expected to come out 1 year ahead as stronger because of what they've done to deal with the pandemic, especially hospitals, healthcare providers, and medical testing companies. And while the constant news feed these days continues to drive a sense of pessimism, the table on the right shows that 3/4 of Americans are still willing to pick at least one of these elements of our healthcare system that will come out stronger. However, let's note that most of the views Most views of companies that manage electronic health records, insurance, and pharma companies are not changed based on their pandemic-related actions, and few pick them as coming out stronger after the pandemic. Perhaps in these areas, their performance and value is still being assessed, or said otherwise, more is yet to come from these in the minds of Americans. I hope the polling provides valuable insights to help understand public sentiment and behavior in ways that can help you navigate through this challenging time. And with that, I turn it back to Nancy to continue our conversation with all of you.
Nancy, you're on mute.
Hi again. Hello. I wanted to thank Christine and really launch into one of the most provocative aspects of the data that Christine just presented. There's so much there, but let's start with a look at the vaccine situation. It's pretty startling, I feel, to see that there's very little difference in attitude since last year, even with this. I'd love our colleague, Bill Pierce, to comment on this. Bill is a colleague of ours at APCO with a wealth of experience in public affairs and communications. He's also worked extensively in the federal government across multiple divisions, CMS, FDA, NIH, and he has a perspective really on vaccines that is broad but also deep, having followed the vaccine literacy issue for many years and had much to say about it. Bill?
Thank you, Nancy. Yeah, so we've spent a lot of time working on this issue of vaccine safety for the last decade or so. And I think what's most interesting is that, and I think what's going on behind the scenes here to understand this, because one might think that safety-related issues might go up at a time like this when people clearly feel like vaccine has been positioned well as extraordinarily important in terms of controlling this pandemic. But what we do know, for just historically speaking, is this issue of safety is really quite hardwired almost into the public. In terms of, it's a relatively small percentage that have concerns about it, but it is fairly hardwired. So we haven't really seen, as Christine alluded, to much change over the years, not just in the last couple of years, but over the years, we haven't seen much change. But I think what we are seeing, and again, we do see this when actually confronted with reality, because part of the issue is these issues are so ingrained because we've never seen polio in this country. We don't see measles that much anymore. So these are a lot of these are diseases that we don't have a lot of actual experience with anymore. So people don't change their point of view necessarily when it comes to some of these fundamental issues. But regarding this one, we're now faced with something very, it's right in front of us. We know people who have this virus. We can see the reporting, the news media, it's relatively relentless. So it's also just the nature of people to want to be hopeful about something, and vaccines are that hope. But I don't necessarily think it's going to, oddly enough, change in the short term. We'll see about the long term. I don't know, Kavita, and I might kind of throw it to you a bit, just in general. You're a physician, so you actually are out there oftentimes talking with people on issues like this. Any thought?
Yeah, absolutely, Bill, and thanks to APCO for having me. I'll be brief. I'll kind of make three comments. On the vaccine front, I was joking but serious with colleagues who were telling, we were all talking about how when a vaccine is available, we'll probably have kind of the highest compliance or adherence rates or demand for it. And that's just with healthcare providers alone, obviously. And then the second point is kind of related. There's a lot of fear, I think, just because there's so much that's unknown, and we're all hearing about what seems like an inevitable second wave, meaning we might get a reprieve in the summer months and then we'll have a fall kind of wave. And we're doing the math like all the country is, that we will not have a vaccine for that. So there's this fear amongst patients and health professionals alike that even though we might bend the curve now, what's going to happen then? And then there's a kind of a third fear for those of us who are in the healthcare profession, but have kind of like all of us, a mix of policy background. There is no such thing as like a perfect vaccine. And there is no, you know, I like to say, like in medicine, there's no free lunch, there's no silver bullet, there's no panacea. So what do we do if and when we can ramp up and I won't even limit it to vaccines. I'll talk about treatments as well, because we have no FDA approved treatments, but we will, hopefully in months. What will happen when we have a very large percentage of people that either for different reasons are not appropriate for treatments or receive a vaccine and still get infected and die? And it's just bringing up, to be candid, it's just bringing up a lot of kind of anxiety amongst health professionals who normally we feel like we have a clear path forward, and we just don't. And so that's at least the reality on the ground.
And
You know, hold that comment hold that thought, because I want to come back to you in a little while about this broader issue. And just ask a couple of others to comment. One thing I wanted you to do, Jack, if you could, is look at not just the challenge, but kind of where the opportunity is right now. You're looking very carefully at how companies in the private sector are interacting with both state and federal government, and the kind of opportunity there is now, really not just opportunity, but mandate for there to be more collaboration and more visibility and how that's happening. And I would love you to make a quick kind of thought about that. Jack joined us from HHS just about a year ago.
Yep. Thank you, Nancy. This is such an important topic, and it's one that, you know, these days that partnership is sort of focused in the headlines by the $2 trillion recovery stimulus bill and all the money that is going into so many places. But what isn't noticed as much is what occurred after 9/11, and that some people that are on this call, like Peter Urbanowitz and Bill, were part of. And over time since then, bipartisan majorities have approved, which are ways that HHS in particular, the federal government, can incentivize companies to do the great things, many of which are doing right now or on the cusp of making announcements. So even though there's this infusion of money right now that we're all hearing about and that's so important, including a lot to hospitals, there's a lot of work behind the scenes that's been taking place. And a lot of that is a result of not only the ingenuity, innovation by the private sector, but the encouragement of that through arrangements such as this BARDA organization, which is embedded within HHS. And looking at some of the polling data that Christine and her group did, it's nice to see, for instance, that 73% of the public sees a partnership between the government and the private sector occurring, and they see that as a positive. So I'm not sure everyone understands the ins and outs of all that about BARDA, but I think people are sort of getting it, and they're seeing that kind of partnership.
Yeah, and thank you, Jack. And that's actually a really good kind of segue to speaking with Peter Urbanowitz. He's the former chief of staff of the U.S. Department of HHS, Health and Human Services, and he was responsible for coordinating the HHS's operating agencies and staff divisions with an annual budget of $1.3 trillion and over 80,000 employees. I guess trillions are now what we're talking in these days for big issues. And Peter, if you can help us understand, especially those of us who are not inside the Beltway and Washington experts, I will raise my hand as one of those people. Where does the money go when there is stimulus money available? There is money that can be allocated. That's one question that would be very helpful. And another is, can you talk a little bit about what's happening in the hospital world? That's a world that I'm very familiar with as well, but you're kind of seeing it on a macro level.
Sure. So starting with, I think the way HHS is thinking about this. So you have almost $150 billion, actually more than that, going to be directed through HHS, some for items like vaccine development and treatment development to jumpstart the work already being done by private organizations, private companies, universities. But then the largest part of that is this $100 billion public emergency fund, which HHS and the Secretary has broad discretion on how it's going to be allocated or how it's going to go out there. Secretary has said in the last couple of days, and I know this is the mindset of HHS, is it won't help if that money goes out the door slowly through some kind of laborious grant-making process and the like. It's going to make the biggest difference if it can go out the door very, very quickly. So $100 billion in ordinary times is an awful lot of money. But in the context of what we're dealing with, $100 billion is not that much money. Just to give you some sense of perspective, you did say $1.3 trillion annual budget of HHS. Most of that is Medicare and Medicaid. So of that, this is about 1/10 of what we spend every year on Medicaid and Medicare. But with that, they announced a few things already. One is that a good portion of that fund will go to pay for uninsured COVID-19 patients, so that hospitals and physicians and others seeing these patients will know that everyone will be paid for in some form or fashion, either through Medicare, Medicaid, private insurance, or now through this $100 billion fund. There are some estimates out there, though, that say that could take up as much as $20 billion of that fund. The next, I think, important thing they want to address are the hospitals. And how do we get money into the pockets of hospitals? As you said, I've probably talked to and working with at least 24 hospital systems over the last 3 weeks. Having the liquidity right now for those hospitals is essential. Most hospitals have carved out or stopped elective procedures, elective surgeries, many of which are covered by private payers. And that's one of the greatest sources of their funding. So they still have all of these staff costs, in fact, increased staff costs, supply costs, and the like, and they're not getting this other income coming in. So I think one of the things the HHS wants to do is make sure that through this $100 billion fund, as well as through Medicare advance funding, that the hospitals are not going to be in a liquidity situation, and that CMS is going to act, if you will. I've used this metaphor, and I think it's appropriate, and they've been doing it, is CMS is acting like the Fed of healthcare right now, and ensuring that those critical parts of the healthcare system have the liquidity they need to pay the staff, pay for the supplies, so that they're not having to worry about funding while they're treating at least now thousands, will be tens of thousands or more patients.
Yeah, thank you, Peter. And it really is so many parallel tracks that I'll have to figure out how to work at the same time, including the expedition of the money, getting the money to the right places and the right people. There's so much about this that's transformative. Kavita, you commented a little while ago on vaccines and treatments in general, and I just wanted to ask if you could kind of speak a little bit more. Dr. Kavita Patel is a health policy specialist, board certified physician. She specializes in issues such as delivery system reform, coverage, and quality. And of course, now with all the changes that are going on, that we have to reform regardless. She's actually been very sought after as an expert to advise on this in many different contexts. Kavita, employers are clearly part of this as well, and they have such strong relationships with certain provider systems and not others. I know we use the term new normal a lot, and it's probably way too simplistic, but as we look forward, how should healthcare change? Who's responsible for healthcare? How does this affect the role that employers really have in supporting the health of their employees and the relationship between the employee and the healthcare community? So
yeah, sure, Nancy. And I spend a lot of time, by the way, most health systems are the big employers in their areas, so they're struggling with the same question. But I am trying to figure out with a number of others on how we can actually kind of stitch together what I'll call the new normal, as you refer to it, and also a road to recovery in general, because we do know that as cases decrease and we're still continuing to use these kind of strong mitigation measures, we're going to have to prepare at the federal and local levels for what does recovery look like, knowing that there'll be a large percentage of the population that is not infected. but there will still be, we won't drop to 0 new cases throughout the entire United States in such a fashion that we can, not anticipate hotspots, et cetera. So there's been a lot to do. Senator Cassidy, a number of other leaders have kind of called for, blood-based testing that shows whether or not you're immune, and then that can be a little bit of a, I'm paraphrasing, but kind of a license to go back to work or a license to return to school. It all sounds good in theory, but we're already trying to deal with the fact that we don't have necessarily, the most effective tests yet. We think that'll get better in the next several weeks, but we've already seen that our country is exposed from a risk standpoint with not having the infrastructure to deploy those tests. So we're going to have patches of kind of gaps no matter what. And so employers today have already started, big and small, but mostly the big ones have already started to think about how can we decentralize the healthcare needs of our workers to both provide them a path to come back to work. But then I think most importantly is that while you are at work, having access, and I'll just say that as Christine showed those slides, the kind of interest in telehealth, I think even despite coronavirus and some apprehension with private information, the interest in telehealth is real, and we now know that we can do it. I'm involved as a board member and then personally in 3 large major health systems, and we have gone from 1x to 1000x in our telehealth capacity, and that stuff doesn't go away. So I do think that employers are now also going to be kind of embracing how can we provide as a material, not applied towards the deductible benefit that can actually, no copays, to get access to care while they are at work. And I think that'll be critical.
Thank you. Both Peter and Kavita, a little bit more about telemedicine, telehealth. There are so many different aspects of it. And because it's a relatively, I don't want to say new term, but not in our everyday vernacular of most people who are not in healthcare, I think it'd be great just to spend a minute talking about the breadth with which we're talking about, the kinds of things that could be, that are increasingly and could be even more handled from a distance through telehealth or telemedicine systems.
Sure. This has been a debate at CMS and HHS for some time, is how do we use telemedicine? And there was a great reluctance for a long time because there was the concern that telemedicine would be used abusively and not really being used as a therapy, but just as another opportunity for providers to increase their revenue stream. So it was very difficult to get telemedicine as a benefit, or at least paid for under the Medicare program. When I was there, we expanded what we were doing in the rural setting, just simply because you don't have the physicians and specialists that you need in a rural setting, and you want to not make people drive long, periods of time to get treatment. So I think Medicare has a change in the way that it's looking at it and paying for telemedicine, and I think you will now have that sea change, and you'll see an expanded amount of items being paid for by Medicare for telemedicine. And as Dr. Patel will say, that it's not just seeing your doctor or a nurse practitioner on your cell phone. There's many other ways that we can interact with patients through wearable devices and the like, and we have to figure out a payment mechanism for that. And I think CMS prior to this was getting there. I think this is just going to intensify with Medicare and Medicaid payment for telehealth. And as Medicare goes, as Medicaid goes, the private payers follow. Although many of the private payers, private insurance companies, are probably well ahead of where Medicare even was on paying for telehealth.
Yeah, Peter couldn't have said it better. And I'll just say that I think what's interesting is you saw some of the attitudes about kind of patients. I think what's really also interesting is that, there's been this cultural divide with doctors who don't want to do it, to be honest. Like there's always been this, I think, sentiment that you can't do, quote, real medicine over video or phone. I would just say, broadly speaking, not just for myself, but just broadly speaking, everybody, including proceduralists, surgeons, are getting used to the idea that over a Zoom webinar, we can glean a lot more information. And to be honest, we don't need the stethoscope, as much as we thought we did. And kind of Peter is correct. It's not just remote monitoring, but there's a trust now because we've all had to do this way. And I think what's even more compelling, most of our hospitals in the DC region are seeing more and more corona cases, but we're seeing less of the kind of other reasons that people come to the hospital. And we're all trying to decide, is that because people really didn't need to go to the hospital as much as we thought they did? Or we're dealing with things before they came to the hospital? And it's probably all, like all things in life, it's probably all of the above, but it's a huge game changer. And when people like all of us on this panel have like a breath to kind of reflect on what worked well in COVID-19, I think it is going to be this ability to connect virtually and have a meaningful effect on someone's health in a virtual manner.
Absolutely. I'm going to turn this, open this up for questions from our guests, our non-panelists, and not me. I did want to ask Bill Pierce one thing real quickly. Having been through several waves of, disasters or near disasters, that where our federal government was in the middle of it, but it was really something that affected everybody in the country and in some cases everybody in the world. Do you see this as, or how do you see this as kind of qualitatively different, not just it's even bigger? Is this a tipping point moment where the things that we've learned from other recent issues, whether they were medical or natural disasters or, man-made, is this a moment when all those things can be brought together, or should this focus right now, really be about healthcare and protecting and public health?
Yeah, I think I'll be brief, but I think this may be a tipping point. I mean, the one thing about tipping points we don't know is they're easy to spot looking backward. They're very difficult to spot looking forward. It's easy to figure out. But if you look at some other huge societal tipping points in this country and around the world, we know what those tipping points were. While 9/11 wasn't necessarily a tipping point for healthcare preparedness, perhaps, it was a tipping point in terms of how the world collectively looked at this issue of terrorism, because it became something we all face. And we all are facing this now, and we're facing this going all throughout our populations. There is no, this virus knows nothing of any issues except one, and I want to bring that up and kind of get the reaction of our listeners and viewers as well as panels. So again, knowing how challenging it is to determine tipping points kind of as you're in the middle, I think this is that tipping point because of its breadth. It's everywhere in the world. Because of its depth, it is throughout the population. And because of its impact, it's not just a sector or a state or something like that. Is in fact, the impact is everywhere. The one place where I would say it is especially interesting and tragic is the issue of chronic disease, which for years has been an issue that the healthcare system has been focusing on, oftentimes as something that drives the cost of healthcare in this country. But one thing it's also showing us in this case is that's where the huge risk is. So for those people who are at highest risk of getting the coronavirus and highest risk of having a bad outcome, the worst outcome, of course, death, but even just severe illness, are those people with chronic illnesses. So my hope, and this is a hopeful thing, is this will help us, a tipping point, double down on the need to address this issue of chronic disease, not just because of the cost, but because of the health-related issues.
Right,
so.
Absolutely. And chronic disease being things that can be incipient, where people think they feel okay, but actually they're not, because they have diabetes or a cardiovascular condition that they're not aware of, or not aware of how undertreated it might be.
Right.
I want to hear more from everybody, but why don't we open this now to questions from people who are outside. I'm sure you have lots of them. I will let you know that we are, as I said, in addition to recording this will not be the last time we create a forum like this. We know that there's a lot to talk about. So why don't we start with, there are a number of people who are asking questions. I guess will you unmute? Here we go. Can you please unmute Jane? Well, I guess I can read her question. Jane Bonvillian wanted to ask the panelists, she wanted to say that the number one increase that she sees, one reason that she sees a decrease in the number of people coming to hospitals is because we've been telling the public not to go to the hospital unless you have severe symptoms that could be COVID. How much is that factoring in, and how is that responsible? What are people supposed to do when they have to choose between staying home and being worried that they're sick or going to the hospital and contracting COVID? Not an easy one.
This is Peter. I think, two things are going on here. One is clearly, people are concerned about going to the emergency room. I was talking with one of the largest emergency rooms in the country this week. They average about, large public hospital, they have about 600 to 700 visits a day. And last week, they had about 200 visits, which is remarkably small. And most of those were COVID-19 suspicion related. They had some other traumas and the like. But yes, people are not going to the emergency room. They're finding other ways to access, calling maybe their physician, or calling the emergency room, or calling someplace to get some direction on what they should do. The other thing that's happened, obviously everybody knows, is all elective procedures have been canceled or postponed. And, when you say elective procedures, that some people think, well, that's, things that you really don't need, but that, elective procedures, fall in things like screening mammographies and screening colonoscopies. Clearly those are needed, and there's going to be a very pent-up demand for that when we get to a place where we feel we can safely conduct those. But we're also going to put more of the population at risk if we don't do those things in healthcare settings. But I do agree, less people are going to emergency rooms because they've been either warned off or scared off from going there and trying to get their treatment elsewhere, or unfortunately, in some cases, maybe not getting treated at all.
Thank you. Another comment is from, I'm not sure the person's name, but I think it's Oliverest or Olivier. One of the things that this person is tasked with doing is trying to plan work operations to minimize the potential for exposure for personnel that travel for field work. So this person is saying their job is to go into the field. Is there a benefit to wearing a cloth or non-approved respirator in general outside of work activities for individuals who just have to travel to get to work? Do you want to take that?
I guess I'm not sure if that was me, Nancy. I'll take it. I mean,
it was you. I mean, I can make a general comment, but you're a doctor.
I think everyone should probably wear a non-medical mask, especially if they're going out anytime in the next 2 to 3 months. And I think the key thing here is to remember the mask does not protect you from others. It's the other way around. It protects them from you. And that's really the most critical role of a mask. So it should not replace, it should only add on top of hand hygiene and all the things that that individual will have to do. But I really do think that, a couple of my colleagues think that now we'll have a very different kind of new normal where many Americans will wear a non-medical mask kind of as part of their just routine kind of daily living. I still find that a little hard to kind of swallow, to be honest, but I do believe that there will be a proportion of the population that does it. And certainly the person that asked this question, I would say unequivocally, yes, you should wear a non-medical mask. I do when I'm out walking in the neighborhood. I'm getting used to it and it's fine. So yes, I would.
There's been a dramatic change even in the past couple of days of people understanding that. I think there's one of the things that I think we need to continue to look at in our research and in our consulting with our clients is the tremendous amount of basic health and science literacy that would make a difference at a time like this, so that people are better equipped to make decisions, whether it's making an informed decision about a vaccine or understanding why there's a reason to cover your mouth even if you're not coughing. So there's a lot there to unpack. One of the things that Jack has been having some really interesting insights on, I just want to spend a minute more on, Jack, related to a time when it's almost like we've all been stripped down to our most basic humanness. We're all part of this species, as Bill said, that doesn't discriminate, and we're all in it together. At a time like this, it makes companies in the healthcare industry especially important in that if you're in the industry, you're both generating support and maybe even some solutions and treatments and cures and preventions. And at the same time, you may have anywhere from 10,000 to 150,000 employees who themselves are at risk and have their own families far flung around the world. So curious, Jack, I have a point of view about this. I think it's a time when companies should be more, should use the moment to engage more with their communities that are far flung, not just the ones that are nearby. And I'm curious as to what you think about that.
Thank you, Nancy. Yep, this is such an important topic. It's one that I actually wrote about yesterday, published a piece on, having to do particularly with the pharmaceutical industry, but it really goes more broadly than that. In Christine's research, they looked at how has your image of various parts of the healthcare society changed? And for doctors, it's gone up either strongly or moderately, 68%. And for hospitals, it's 66%. Pharmaceutical companies, which have been sort of the whipping boy and have been folks have been coming at them from all sides. Their own reputation has gone up by the public by 40%. But I think you're right. Now is this incredible time when we're stuck at home. So many of us are watching cable news, and I don't think there's ever been a time, in fact, there hasn't been a time when so much focus has been on public health and the first responders and our wonderful doctors and nurses and everyone, and at the same time, the innovators, whether they're working at a pharmaceutical company, whether they're at NIH, whether at the FDA, fast tracking these important approvals, whether they're with medical device companies that are quickly getting these testing devices quickly to people. So I believe that there is a short-term bump that we're starting to see, and that should continue. And then the question is, will people have short memories? Will there be issues that then haven't been dealt with well? Will there be public policies where people are split? But the main point is that right now is a time when people are focused on innovators and researchers, and that's a good thing, because frankly, I don't think enough time has been spent with people really understanding what is the ecosystem that these innovators are working in, and how do we keep it in a positive way so that we can have as much R&D and innovation so that at a time like crisis like this, folks can respond.
Thank you, Jack. Well said. So we have a number of questions now. So I'm going to try to cover all the ones that are different from each other. And let's keep our answers real short so we can go through as many as possible. Interesting comment from John Gavin asking, what does this mean for healthcare design and construction in the short and longer term? And because he said construction, I will take that to mean kind of the built environment that houses our healthcare, some of which are in major tertiary care and quaternary care medical centers, and some of which is not so centralized. So I guess I'm going to kick that off by saying, and then I'm going to turn this to Peter. I'm going to kick that off by saying that the disbursement, the distribution, if you will, of accessible technologies and access to specialists through telemedicine and telehealth was already a need and happening, and that this is accelerating that in terms of how things are built. It's interesting that you said in this question, healthcare design, because I think there's also significant implications for design and construction of things that aren't for healthcare, but that affect people's health. But let me turn to Peter and ask him about specifically design of healthcare facilities.
Well, over the last certainly more than 10 years, maybe even going 20 years, we've had these arguments about our country and other countries, certainly the United States, being overbedded. We have too many hospital beds. We have too much capacity. We're paying for lots of capacity that we don't need. We need to have more certificate of need regulation out there, limit the number of hospitals, et cetera. This crisis has sort of upended that argument. And in states that don't have certificate of needs, you actually have an abundance of hospital beds and ICU beds. And in places where construction is more strictly controlled, you're seeing capacity issues very quickly. I think this may change the mindset in terms of what we need. And we need to start looking at acute care hospitals like the fire department down the street, the firehouse. We pay for firehouses all over the city, and many of them, thankfully, are only in use a couple of days during the year when they're responding to fires or emergencies. We need to start thinking about our acute care hospital infrastructure like that. And for those hospitals that are a little bit older, that were built as, you used to have 2 beds in a room. There's very few hospitals like that anymore. For those hospitals that still have that capacity, that's exactly what they've been doing. They've been putting 2 beds in a room, 3 beds in a room. And so I think from the acute care hospital perspective, I think what you're going to have to do is go back and look at how can those facilities handle a major pandemic like this or a major trauma crisis, so that we're not trying to construct beds on a convention center floor. Clearly, this will outstrip anything we might ever design. But I think for the acute care hospital world, we have to think about how does this help us in the future build capacity for emergency capacity, because I think that's something we're going to want in the future. But on the other stuff, we're going to have to build out the technology aspect, because while we'll want that critical infrastructure for emergencies, it'll still be better and cheaper to devolve activities of healthcare into the home, into lower cost settings.
Yeah, thank you. And in fact, there's a couple more questions that kind of build on this topic, which I think are worth continuing to consider, particularly this idea of kind of migration of even sophisticated care outside of the major hospitals to smaller hospitals, urgent care centers, physician offices, and in some cases, other places in the community where mobile technology and a greater understanding of the many kinds of healthcare workers who actually are equipped to do some of this work out in the field is going to make a much more dispersed healthcare system. It would be interesting to ask all of my colleagues, actually, with so much regulatory background, yourselves in the U.S., do you think that this hospital and IDN kind of consolidation is going to accelerate things so that there's less friction in decision making in the future? That in the future we'll have some of these barriers broken down so that we'll be able to more quickly bring things to market or test them or get people access to something, even if they're not near a major medical center?
Hey, Nancy, if I could, I'd like to jump in, and then I'd like to kind of pose this question to Kavita as a physician. I think one of the things we're seeing now is the incredible use of technology, electronic health records, in this era when we have to go from the inside the hospital to inside the some convention center, wherever it may be, in New York or Chicago or wherever it may be. I wonder, Kavita, there has been some friction with physicians and electronic health records. Is this also a moment when we're seeing the benefit of this? Yes, it might grate on physicians a bit, but the benefit of it is because we can quickly expand into new places for delivering of care. And even you can expand into that clinic, and maybe the physician is actually at the hospital, but through telemedicine through a handheld, you can actually communicate with that person in the clinic differently than now. What do you think?
Oh yeah, absolutely. And I'll even go further to say that I think we're actually pushing our own electronic health record vendors to kind of do, I mean, so yes, and we're even trying to push the EMRs, which in general, kind of in terms of technology development, have kind of lagged behind in their own innovation. So we're trying to push the EMRs to really catch up to where, we're using it today, right? We're using Zoom and call out where there might be criticism. It's facilitating a lot more. And we're asking our own EMR vendors, how come you're not stepping up and facilitating, for example, something like hospital at home and some of the things that I think Peter might, kind of be referencing when we talk about a redesigned healthcare system. So I absolutely. And the other thing you're seeing is you've got a younger generation, not just of physicians, but you've got a younger generation of health professionals who didn't know paper and pen like me, and they really don't see how we can go backwards in any way. So, and you were in the Bush, both you and Peter and others were in the Bush administration when I was on the ground after Katrina, and I remember having this like patchwork of, paper and spreadsheets and Post-its. So it's amazing how even in that short of a time, how far we've come. So this is one of those things we're not going to reverse, and hopefully we will accelerate, because as you know, there's been all these kind of infighting about interoperability. Despite some clear guidance from HHS, there's still kind of what I feel like are kind of antics around not getting this true universal interoperability. And I think that you're seeing that there's now a lot more of a tailwind to overcome that.
Yeah, I think that's very true. I agree completely. I think the industry is going to respond and is responding. We're going to start to see that unfold quite shortly. So.
Okay, well, hopefully. There's still so much to go. It feels like we're all getting exhausted at this point, but we're still like in the beginning of all of this. I thought maybe Christine Zaccaro might want to take this next question. There's an inquiry about Gilead's activities at the end of last month to withdraw orphan status for remdesivir, which everybody here knows is being studied for treatment of COVID. Wanted to really, hear what our research has shown, what our experience of late has shown about the impact of this on health disparities, given that so many of the fatalities are now coming. It's become very clear that people who are brown and Black, as well as people who have chronic illnesses, are at greater risk, or at least seem more likely to become very ill. So, Christine, what do our data, not only just from this study, but just in general, show us about healthcare disparities and the opportunity to address them more aggressively during a time like this?
So I'm not sure that we have much data at this point that's going to address public perceptions around these disparities, but I think that certainly what we've already talked about here today is that there is a sense that there are shortages, and that getting care is a challenge for folks regardless of where they are, but only gets accentuated in areas where there were persistent issues that preceded the crisis. I do think that folks like Kavita or Peter might have some other points of view to share on this as well.
Maybe not quite yet. While they're thinking about that, another interesting comment and question that's come in relates to really policy and how to make policy when there really isn't one, around who goes to work and who doesn't. There are certain industries and companies that make certain kinds of goods or provide certain kinds of services that are still operating, although in a different way. Arguably there are some who say, well, even those employees should be home and sheltering in place. And we still have too many people out in the workplace doing jobs, and is that in the best interest of the public health in the short term, and even the economy in the longer term? This is a very, I will just start by saying this is a very debated point. And if you had a room full of 100 experts on this right now, you would not have consensus. Having said that, I would love to hear thoughts from Peter, specifically around business as usual, and what does that even mean now?
Well, I have some real life, well, we all have real life experience in this, but mine particularly here in Dallas County in Texas. For the last couple of weeks, I've been working with, at the request of the county judge, who's essentially the county executive, and the medical community here in Dallas as a volunteer to not only help the hospitals work together, but also figure out these social distancing stay-at-home policies. Dallas County was the first county in Texas to have a stay-at-home policy. It was the first to start with closures of restaurants and schools, movie theaters, auditoriums, all of those things, getting now down to a pretty strict stay-at-home with only essential services being available. Of course, the big debate is what's essential, what's not essential. And it's clearly having a huge, terrible economic impact on large parts of the economy, large numbers of people, hundreds of thousands of people at least in Texas and other states too, individuals who work in the service industry, who are at restaurants or hospitality or anything like that, who can't work from home. On the other hand, we know from a public health perspective that the congregation of large numbers of people are what drives up infection rates. And so the places that you have to go first are the places where people mass and where you have the probability of exponential infection. And that's at schools, that's at universities, that's in movie theaters, that's at sporting events, that's at, it could be at barbershops and things like that, certainly restaurants and other large gatherings like that. It creates huge economic losses. It creates huge unemployment. On the other hand, if you want to slow down the spread, if you want to, is probably this may be the phrase of 2020, flatten the curve, but really when you're dealing with a virus where you don't have effective therapies and you don't have an effective vaccine, you literally are drawing on a public health playbook that was drawn up many, many centuries ago. And really, this is the only thing that works. And there's a lot of pain to it, but you can see in cities like Dallas, cities like San Francisco, that got pretty aggressive early on the social distancing stay-at-home standards, you have seen a moderation of case growth. So it is working. It's hard. It's probably some of the hardest medicine of all to take, but it's the only medicine we have right now. And I think we have to maintain the course for the next couple of weeks, and maybe even into the months on these social distancing policies.
Well,
Nancy,
I'm sorry, go ahead.
I was going to jump in and say, if you listen carefully, and Kavita, I would be interested in your thought. If you listen carefully to Dr. Fauci, everybody's hero, I think, at this point, what you start to hear him and others saying is that through expanded testing and learning about this virus, we may be able to do a kind of gradual moving back into opening up our economy on those people who are at the lowest risk of getting this virus, is where we start first. And maybe it includes also those people who have had the virus. Maybe, again, science will tell us if that provides some level of immunity. But if you listen carefully to him, that seems to be the direction he's going in, and others. So Kavita, I'd be curious on your thoughts on that.
Yeah, and I think they're also trying, just briefly, I know they're also, they being the NIH, sorry, I know they're also trying to kind of set up, an expectation that it'll be kind of community by community, whether it's states or kind of to Peter's point, county-based surveillance, that while we are doing that type of testing, we are also going to have infrastructure in place to do kind of what we call in public health contact tracing. I used to do this on tuberculosis patients back in the day, and it's literally this kind of, by hand trying to figure out who did Kavita come in contact with, or by GPS on your phones. So I think Dr. Fauci and others have been trying to set an expectation about this new normal. And it's just, I think all of us are so hungry to go outside that we're willing to just do whatever we can. And I think employers are in that same bucket, by the way, for very, very critical economic consequences.
Right. And that's why we're in a situation, and we're going to wrap this round of this meeting. We're really in a situation where we need to look at transforming everything, because in order to transform public health, we're going to have to transform a lot of systems that we didn't typically think about as part of healthcare, like transportation and office and housing. There are more interesting things that came up in this conversation that we're not going to be able to cover right now. We are capturing them. I do want to be mindful of everybody's time, but we will be hosting additional talks, and we look forward to, I really would welcome any suggestions that people have about what they'd like to hear more about. I think we do have to have one that's very specifically about companies that are in the business of healthcare and making healthcare products. How could they participate and contribute with the best leadership possible right now, when people are watching for them and wanting to hear from them. And I think another one is industries that are not in the healthcare industry, but what does this really mean? Not only about how we manage our employees, how we manage our offices, but even how we build things and how we set things up so that we're prepared. I'm going to adjourn the call because it's already 3:04. On behalf of Jack Calavertinos, Bill Pierce, and Christine Zaccaro from APCO Worldwide, my colleagues, and our very close advisors, esteemed advisors, Kavita Patel and Peter Urbanowitz, I want to say thank you to everybody. Stay safe, stay inside, and we look forward to any further comments or questions that you will send us so we can use that to build the next round of this. Thank you so much.
Thank you.